69 years old female patient with a medical history of diabetes and blood hypertension, which during her screening with renal MRI was discovered multiple pancreatic cysts with the normal main pancreatic and common biliary ducts. So EPMN was suspected. As we can see at those images, we have many cysts at the tail and body. So this is a recent study made from Tanaka that described some criteria for brain duct EPMN. So the presence of pancreatitis, dilated main pancreatic duct, an irregular duct, and also a non-enhancement of a mural nodule and a cyst higher than 30 millimeters was trouble. Another study published showed that it's a concomitant presence of adenocarcinoma and EPMN was the rate about 3 to 8%, with a very high association with panning. So the next case will be performed by Professor Dietrich and Dr. Sahai also.
In that very relaxing position, there is a strange lesion which can be seen here. Let's have a look about the size of this strange lesion. It looks like 8 millimeters. Can you see that? Okay, now this is really strange because you can also see by turning the instrument from the right to the left side that this lesion is tubular. It's not a mass lesion. You would, for a neoplastic or a tumor, you would assume it's round and it takes really all that growth into the round volume. But this is not a mass lesion. It's a tubular structure. So I'm coming a little closer, take the focus right on here. I use a slimline echo endoscope by Pentax and I also display for resolution that we can see such nice images, tissue harmonic imaging and also the compound scanning to get best image quality of such tiny lesions. So the next step at this stage is easy to push the button. So I push the button of elastography. And we can nicely display, and we have a reproducible image that this lesion of 8 millimeters, we can see here, seems to be softer than the surrounding. We cannot tell it's stiff and hard. We can only say it's softer. And we know from our small pancreatic study that almost all pancreatic ductal adenocarcinoma are stiffer. So we have a softer lesion which is tubular, and we would perhaps see if there is vascularity within. So I push the button for a color Doppler imaging and I reduce, you might see to the left side, the sensitivity to about 3 centimeters of the pulse repetition frequency to get sensitive image. But if I turn up the gain, I get artifacts, and therefore I know I have pretty good sensitivity right now, and we do not see any vascularity in this not tubular structure.
Chris, when do you use the fine flow?
The fine flow, since I always love to have the directional information, I rarely use it, knowing that many people might say that there is better sensitivity. But I would always love to see the direction, and honestly I prefer, since all my studies are done by color Doppler imaging, as an adjunctive tool. I like it for sensitivity, but it's not my big tool. You can see it right on here. So now we would switch for the contrast mode, and you can see on the right side the B mode image, and on the left side you can see the contrast image. And we can go for resolution, since this is in the near field. You have the opportunity to change from penetration. You can see it right on here, the R, which is resolution, to P, penetration. And you get a better resolution by R, by resolution. So we optimized our image, and we are prepared to inject SonneView. Go for gold. So the idea is always go for gold, and you can start. That's fine. Excellent. And we're waiting a few seconds. Finish. We are still in the image, and we can nicely see that this lesion, I put in a little bit microbubble tracing imaging, and we can see that this lesion I mark on the right side, and you can see on the left side that we couldn't detect larger vessels, but right now there is micro perfusion, and this can be nicely seen during the early screen. And if you like to increase the sensitivity, and if you have a stable position, it's always good to use the microbubble tracing imaging. That means you have a plasticity mode, putting one image over the other to get the best detail resolution.
Looks really cool.
Out of that. And be aware, we are still thinking that this is two 7mm lesion. After knowing that this lesion is almost the same enhancing compared to the surrounding pancreatic parenchyma, and we see it's a tubular structure. It's somewhat strange. I have finally no histological idea, but from this part I exclude ductal adenocarcinoma because it's hypovascular and it's stiffer. I exclude any, I would exclude from this point of view any other neuroendocrine tumor or malignant structure, because it would behave in a round fashion, not in such a tubular fashion. Have a look, it's tubular. And Mark, perhaps you can help us also a little bit. What is your impression if I see that 7mm lesion, which is soft, one more time, push the button, which is
Could be really
very
just
well enhancing using contrast enhanced ultrasound.
Just a strange hilar lymph node.
It's a node or is inside the pancreas?
It's
It's
inside
outside.
of the pancreas.
Okay.
You think it's inside the pancreas? I'm not sure about that.
And
This patient has an IPMN, huh?
yeah,
So maybe will be a cyst with.
but it's enhancing. So we
It's
have
enhancing.
it's enhancing.
But
It's-
you know that the IPMN, the publication, Japanese publication, they found some malignant IPMN with
Enhancing nodules.
so we should do a puncture.
yes, for sure.
Okay,
Yes, yes.
so let's do it. So perhaps we can prepare a needle. We
sorry to
25,
interrupt you,
what kind
Christoph.
of size?
25.
25 Procore or
Christoph,
standard?
No,
interrupt
a normal cytology needle.
25
Can we try and interrupt you,
normal.
Christoph?
Sorry. Yeah.
Could this not be
Yeah,
a
Vincent,
normal
pardon.
packed full of material?
No, because it's enhancing. So
Well, it
it's
could be full of enhancing tumour.
yeah,
why not?
yeah, that's true, and therefore we try to get it punctured right now.
But you would expect some continuity with the rest of the duct then, and maybe some dilation.
Be aware that
above
this
it
is a
somewhere
tubular
else.
Can you
structure.
show us the duct? We haven't seen the duct yet.
We
The
haven't seen the pancreatic duct.
I'm not even sure this is in the pancreas, though. If you ask, I mean, the image is backwards, you know, but it still doesn't look like it's in the pancreas to me.
okay, one more time. I will show the whole story. Right now we are passing the pylorus. We have still some SonneView inside. you can nicely depict the common bile duct next to the arrow. You can see if I'm playing a little bit, there's no more bile duct because I have really to play softly with my instrument. And you can also see that the pancreatic duct in the surrounding is not at the level of the papilla. Let's have a look quite right on here.
Can you take the bile duct down to the papilla then, just to see the?
Yeah, we will continue right now. Now we have the pancreatic duct. Are you happy with that? So we talk about 3 millimeters. One more time, I show you the bile duct in front of the image. I compress a little bit, like look at my thumb. And we have some sort of obstruction next to the pancreatic duct right on here. So this is also exciting structure. You can see next to the arrow. And then we will follow a little bit further to the distal parts, and we can see the papilla region right on here.
And can you find Santorini? Because if that PD is that big, the Santorini should be sort of visible, I would think, somewhere.
Yeah, the next point is more caudally, and I'm looking to all parts of ducts. We can depict this lesion. So it's at the lower part of the pancreas, and I could even imagine that this lesion we are talking is part of the Santorini duct. So, as you mentioned, we have a tubular structure.
But it stops short of the wall, though.
Yeah, it stops over there.
It doesn't go to the wall. It's weird. It turns away from the wall almost, which would be strange for the Santorini.
Yeah. So I'm doing really soft movements, and
it doesn't look like a Santorini to me. It's very bizarre.
But it's bizarre. We really do not know, and we biopsy, and we will try to get some tissue out of that. Okay.
Please, proceed, my friend.
Je peux le garder au début.
Okay. Put it up. Okay.
So using a 25 gauge regular needle, not a regular needle, yeah.
Have to relax the instrument.
Yeah.
But
So this is the slim scope, so it's a little bit, you have to straighten it out sometimes to get the needle to go in.
okay, right now we have to do it really carefully.
Never force your needle
Never
through the
force,
scope, because
never force
you'll perf the
your
scope.
needle. Still be aware that we have a lesion of 7 millimeters, which is not a big lesion.
25 25 regular needle. It's made by this company called Cook.
So I have to play a little bit, because we know that this lesion is pretty soft, and we have to be aware that we are talking about that 7 millimeters. But as you can see, I'm playing a little bit with that lesion. So that was not such easy, but you can see the tip of the needle. Okay. And then we have a little bit of movements. Perhaps we might be interested to see how that looks on an elastographic image. I always try to learn a little bit more on how to play and to understand. But be aware, what I'm playing with is not stiff. And this is also a good...
It's moving with the needle,
it's
so it
moving.
looks very, very benign looking, kind of, yeah.
It's a very non-ductal adenocarcinoma structure. Right now I'm playing a little bit further. Okay, we are playing within 7 millimeters, be aware of that. Okay, you can shut, close, fermer, voila.
Can you comment on your use of suction for a very small lesion like this? Why are you using suction?
Honestly, I'm not too much interested if I'm leasing suction or not. For me, it's pretty much the same result. Since this lesion was such, you could have used suction or not. You don't use it.
No, well, there's just some, for a cell block, there's some data showing that high negative pressure suction improves the results of cell block, but it doesn't improve the results of cytology. One thing I would just mention is that there's this paper coming out showing that if you measure the amount of suction at the tip of the needle with a 25 gauge needle, it takes at least 30 seconds to get any suction at the tip. So unless you're doing suction for 30 seconds, you're basically getting no suction. It's the concept that suction is kind of a waste of time, because even when you think you're doing suction with a 25, you're really not getting any suction at the tip of the needle. Qu'est-ce qui est sorti? Not much. We've got pretty much nothing. Which is not surprising to me because it's a very benign looking lesion. There's basically nothing here. And I don't think I would be much more aggressive to try and get more stuff. I think the fact that nothing's coming out is kind of suggesting or maybe it's some fat or something. I don't know, but it's bizarre. Pardon? No, je pense pas. No.
Okay, if you look to the pancreas from the body, we see more nodules within the pancreas of about 3-4 millimeters, and we would be also interested to see the elasticity of such lesions, and it looks pretty... If you look for the stable image, pretty soft. Perhaps we can even turn it a little bit more in the near field.
With more lesion?
There are tiny little lesions within the pancreas as well. But the duct is not really enlarged. As you can see here, it's filled with material. And in this case, I would also think about an ERCP wouldn't be so bad to see about. We were unsure about Santorini duct, and we saw that mass within the pancreatic within that pancreatic duct, and you see that thickening of the pancreatic duct, the local thickening right on here. There is no flow, and here you have the duct. Here you have the duct. That's a bizarre.
Do you think that is not an IPMN of the main duct?
It's not a typical one. Because for an IPMN at this stage, I would expect some typical cysts, but there's something in. It could be an atypical IPMN of the.
I think the next step could be RCP, yes, but with brossage and.
But the bottom line is, even if it's an IPMN, there's no signs of
aggressive
malignancy.
behavior.
Yeah. Okay. You could just still follow it by MRCP
Okay,
or something.
we will move for the next case. Thank you, Anand. Thank you, Christophe.